Prof. Anand. So, Prof. Anand is a consultant cardiothoracic surgeon to Sunway Medical Center and SJMC, Subang Jaya Medical Center. He's the founding president of Lung Cancer Network Malaysia, or LCNM, a disease-centric NGO dedicated to improve care and outcomes for lung cancer locally. And I really congratulate you on this because we absolutely need this, actually in all tumor subtypes. Well done for lung cancer for sort of taking this forward. Please congratulate him. He has championed and pioneered lung cancer screening in Malaysia, including adoption of innovative AI, enhanced imaging, and use of biomarkers. A strong advocate for MDT care under his leadership, LCNM has developed several national firsts to enhance lung cancer care, including digital patient navigation guide. Prof. Anand is a clinical professor at Life Sciences, Sunway University, and also adjunct professor in Faculty of Medicine, University Malaya. Can I invite Prof. Anand to give us a lecture on screening and diagnosis of lung cancer in Malaysia, its challenges and opportunities. A huge clap.
Thank you, Dr. Nina, for the kind introduction. Thank you. And it's a pleasure and privilege to speak at this second National Cancer Congress. So I'm going to shift gears a little bit from Prof. Leong's very scientific talk in terms of MRD and ctDNA. There's a lot of correlation as well. And I've been tasked, I just want to share perspective in terms of how we, the challenges and the opportunities that are presented in trying to screen and diagnose for lung cancer today here in Malaysia. So I think we perhaps refresh our understanding about the scale of the problem, the burden of disease. The most contemporary data that we have, which I'm sure all of you are familiar with, comes from our own National Cancer Registry report, which the Ministry of Health through IKN issues a 5-yearly report. This was a little bit delayed because of the pandemic. This is the most contemporary data. And what we can see is that lung cancer across the board is approximately accounts for 10% of all cancers in our country. It is across both men and women. And we can see from 2012 to 2016 across to the more recent data, the incidence is approximately the same. However, when we take a slightly more granular view and we look at the ASR, so ASR is the age standardized incidence rate. And this looks at the incidence of a disease, in this case lung cancer, assuming a population has a standard age structure. And what we can see on the top in blue are obviously for males. You can see lung cancer remains the second most prevalent male cancer, but the ASR has increased from 13 per 100,000 of the population to about 16. And we can see with women in pink at the bottom, lung cancer has unfortunately moved up the league table from being the fourth most common to now the third most prevalent female cancer, only surpassed by breast and colorectal cancer. And the ASR again has moved up from 6.2 to about 7.4 per 100,000 of the population. So I think we can acknowledge that it's a common cancer, and the incidence from our own local data here in Malaysia shows that it is unfortunately on the rise. But perhaps the most alarming statistic which drives the need for screening and early detection comes from this infographic. And we can see on the left for males in blue and on the right in pink for the ladies, we can see the stage of disease at initial presentation. So this is when someone presents to their primary care doctor or to the specialist. At initial diagnosis, we can see both for men and women, there is a preponderance of late stage presentation. We are picking up the disease way too late with regards to lung cancer. Almost 95% of cases are being detected in stages 3 and 4. As we know, that's locally advanced or metastatic disease. And for all the tremendous advances that we have observed in the last 5 years in the lung cancer space, and there have been many, once we have patients in stage 3 and stage 4, we are moving beyond the realms of curative intent treatment. And although we get patients to live longer and with better quality of life, the fact remains it is usually non-curative. They will eventually succumb to the disease. So this underscores the importance. And if we look a bit further, we can see there's also certain ethnic variations. If you're a Malaysian of Chinese ethnicity, your age, gender, standardized incidence is twice that of an Indian and slightly higher than that for an ethnic Malay. Right, so what is the importance of late-stage presentation? As we all know, especially with lung cancer, but with all cancers, but especially with lung cancer, the prognosis, the outcome is very much stage dependent, as well as the treatment that we offer our patients. And we can see from our own local Malaysian data, this is MyScan data from 2018 from IKM. So this looks at data from 2007 to 2011, so it's quite historical now. For lung cancer, we can see in pink we have the 1 year survival, and in purple the 5 year survival. And we can see, as you would expect, how the survival will diminish as we move across the stages. It is quite alarming to see a 1 year survival, for stage 1 at 63%. And I suspect that, I do question some of the accuracy of the data. I think there's some element of underreporting. It could also mean that we need to be more meticulous in how we stage the patients, and some of those stage 1 may not have been truly stage 1. But you can see the point being how the stage affects the prognosis, the survival. The metric we all use is the 5 year survival. Now we contrast that with global data. This is from the IASLC, the International Association for the Study of Lung Cancer. And the best case scenario is if someone had a stage 1A1. That means you have a lung tumor less than 1 centimeters with no spread to the nodes or anywhere else. The best case scenario is you can achieve a 5 year survival, 60 months, around approximately 90%. And we contrast that with more advanced stage disease. Although we are seeing more and more cases of survivors and thrivers with stage 4, still significantly inferior survival. Finally, in terms of survival, where does Malaysia compare? When we benchmark ourselves regionally, what we can see is this is the 5 year relative survival. So this looks at stage 1 across to stage 4. And remember, it's driven largely by a preponderance of late stage disease, late stage presentation. Pretty dismal. Our overall 5 year relative survival is around 11%. Now contrast that with our East Asian neighbors in Japan and Korea, where it's 2 and 3-fold better. And I can tell you what is driving that is that it's stage shift, that they have a greater proportion of their lung cancer patients being detected, being diagnosed at an earlier stage. So it's not rocket science, it's imperative we need to pick up the disease earlier. So at this point, let me just summarize by saying I hope you agree with me, we're dealing with a very high disease burden. Third most common cancer across the board, second most prevalent in men, and now moved up to third most prevalent in Malaysian women. And we are burdened with a preponderance of late-stage presentation, 95% of cases being picked up too late. And as I've mentioned, it correlates with a poorer outcome, and we know the treatments are generally less effective, or certainly in most cases non-curative, and infinitely more expensive. So the way forward really is, aside from preventative strategies, and a lot of lung cancer is still driven by tobacco-related disease or smoking, and therefore tobacco control, which I put at the bottom. But really the focus here is we need to implement screening, the concept of picking up the disease pre-clinical, pre-symptomatic, and it has to be targeted screening. For screening to be cost-effective, for it to be impactful, for it to be meaningful, it has to be targeted screening. And I will elaborate a little bit. But what we are trying to achieve is stage shift or stage migration, to pick up more cases at that early stage, stages 1 and 2, when the cancer is more amenable to treatments with a curative intent, which is usually surgery as part of multimodal therapy in combination with other treatments. And there's a wealth of data and scientific evidence that early stage cancer or lung cancer correlates with better outcomes, and that screening, which I'm about to talk about shortly, reduces the lung cancer specific mortality. So it's not just good enough to pick up the disease earlier. Does that actually translate into survival benefit? And the answer is yes. So at this point, given that the title of this talk was the challenges and the opportunities with regards to screening and diagnosis, so what are the challenges with regards to screening? Well, first of all, we know we have a high disease burden. So, perhaps if you were a policymaker, if you were sitting in the Ministry of Health, you may have some concerns. Are we opening Pandora's box, because if we were to go all out and screen and detect the disease, do we have, enough facilities and specialists to cope? But I also say this presents an opportunity for us to, implement proper workforce planning. Optimal care for most patients with lung cancer requires a multidisciplinary approach, multimodal treatment. So really, it's an opportunity as part of the government. The Ministry of Health has been very progressive in terms of this lung health initiative, but we really need proper workforce planning. as well as resource allocation. We need to ensure we have sufficient specialists, pulmonary or chest physicians, thoracic surgeons, oncologists, radiologists, pathologists, nuclear medicine specialists, and all the allied health professionals as well, pharmacists, dietitians, physiotherapists. They're all integral to the care of a lung cancer patient or any cancer patient, as well as the technology. We need to ensure we have sufficient CT scanners, PET scanners, labs to support molecular testing. We have, like in many countries here, considerable geographical discordance. We have a lot of it is Klang Valley, Greater Kuala Lumpur centric. And we have a urban-rural divide, we have an East Coast-West Coast divide, we have an East Malaysia Peninsula, Malaysia divide in terms of the deployment of resources. But it offers an opportunity to address that. The second major challenge, who do we target? As I said, screening has to be targeted, otherwise it's not cost-effective, it's not meaningful. And we, up until now, all the major evidence, the trial data, quite rightly focuses on individuals with a tobacco smoking history. That means people who are current or former smokers. But we recognize this phenomenon of lung cancer in the non-smoker or never smoker. And you may be alarmed to know that lung cancer in the never smoker is now the 5th commonest cause of cancer-related mortality globally. And this phenomenon appears to be proportionally more in Asia, in East Asia, including Malaysia, compared to the West. So if we were to be rigid in applying Western-derived data for screening just people with a tobacco smoking history, we will miss this opportunity to address a large proportion of people who, a high-risk non-smoker. Another major issue or challenge with screening is the uptake is really poor, okay? And there are many reasons for this, from ignorance to low awareness, to fear of a cancer diagnosis, to cost issues. So we need to address that in terms of education and awareness, a whole of society approach. Cost is important. Very often screening is not an isolated test, it's not an isolated investigation, but rather it's a process where the patient may need a follow-up scan, a surveillance scan. So I see this as an opportunity where, to make screening meaningful, we need to have a sustainable budget. Now, the government has de-legislated vapes, liquid nicotine. They want to implement more tobacco taxation. And what I would like to see in hopes that we can ring-fence some of that tobacco taxation, what they call as a sin tax, and use that to fund specifically treatment of tobacco-related diseases, or better yet, to fund a national lung cancer screening program. It also offers us an opportunity to be innovative and to adopt the use of technology. So the gold standard to screen for lung cancer remains a low-dose CT scan, LDCT. It is widely available, but it's still not as accessible or as palatable as a simple chest X-ray. Historically, we know chest X-rays aren't good enough, but now we know with the use of AI, it is able to enhance the diagnostic accuracy and sensitivity, and this is something that is a reasonable strategy. It is better than not doing anything. It is to complement the LDCT, not to replace the gold standard LDCT, but to complement LDCT. We might be able to use it as a triage to funnel and identify individuals, particularly in low and middle income countries. I suppose Malaysia is sort of thereabouts. So that is something, that's an opportunity to embrace innovative technology and use that to widen the net and up the game for screening. Now, in terms of who do we screen, so I'm happy to share that I led a group of surgeons that we have published effectively the first ever clinical practice guidelines in Malaysia. We presented this a couple of months ago, and I just want to share that in terms of screening, based on our own Malaysian data and obviously published global trials, we advocate screening should be offered to those with a smoking history of 20 years. We've removed the pack years, simplified it in this age group. And the important point here is the high-risk non-smoker, whom we define as those having a family history. We know in non-smokers who develop lung cancer, there is a genetic predisposition, and a family history is a very salient risk factor. With regards to diagnosis and staging, we advocate that any person who has suspected or confirmed lung cancer should see a relevant specialist, which could be an oncologist, a chest physician, a surgeon, within a window of 2 weeks. And in this new era of biomarker-driven, we feel that once you have diagnosed lung cancer, it's not good enough to just establish that it's lung cancer or what type of lung cancer. We really need to do a lot of what Prof. Leong has been talking about, genomic molecular profiling, okay, because it really dictates subsequent treatment. Now, in terms of screening, as I said, the gold standard is with a low-dose CT scan, and that's essentially what it is. It's an example of the LDCT, where you can see a typical lung cancer that is sitting in the upper lobe of the left lung of this patient. I'm not sure if biomarkers are quite there yet in terms of a screening tool. I agree, Prof. Leong, that it's used, we use it as a surveillance post-treatment, post-surgery or response to treatment. We may use it also for adaptive in terms of escalating and de-escalating adjuvant treatment. But at the present time, I think LDCT is the gold standard, and there's evidence that it reduces, not just increases the detection of early stage shift, but reduces lung cancer specific mortality. But our interest lies also in using AI chest X-rays to help complement that process. So there's again a lot of publications now that it enhances the diagnostic sensitivity and accuracy. The value, I think, is in deploying this in a primary care setting, in your clinic, Sachithanandan, in private GP clinics, where you don't have a highly trained radiologist on site, and you can shorten the turnaround time. A lot of these softwares are available, cloud-based softwares. You can scan either an analog or digital X-ray, upload it to the cloud, and it will generate a very detailed report commensurate with a highly experienced, trained thoracic radiologist report within a matter of minutes. And what that does is it empowers the primary care doctor, the GP, the medical officer, even an MA in a clinic, to be able to then decide on the next course of action, which could range from referring to a specialist, to a follow-up scan, to giving them a course of antibiotics. And I think the Ministry of Health, as you're probably familiar, as part of this global, they pushed some global, at the World Health Assembly recently pushed for this lung health initiative, and even on a global level, legislation to make lung health a priority, of which lung cancer is a big chunk of that. And recently, KKM has started with 7 clinics. So this is a typical, uses a particular software that we used with Lung Cancer Network Malaysia. We pioneered the screening a couple of years ago. That's an example of an opacity of potential early stage lung cancer that can be very easily missed in a busy clinical practice, even by a very experienced radiologist. So the AI technology using deep learning algorithms has the potential to sift out, and highlight abnormalities, flag it up, that then obviously require a trained radiologist to have further scrutiny. So happy to say that around almost a year ago, we reported the very first case, LCNM reported the very first case of AI-detected lung cancer. And it shows that the technology is there, that it is feasible, it is technically possible. Of course, how we utilize it, that is the key. And we also published around the time of the pandemic. LCNM worked with a group of primary care, the Qualitas GP clinics, and we conducted over 15,000 screenings. Now, these were individuals who went to their GPs, either they had symptoms or they just went for a routine health check. What we were able to demonstrate is that we detected, on average, 2 to 3% was the IPN. IPN is an indeterminate pulmonary nodule. So, unfortunately, the challenge we faced was in closing the loop. The next step of that process was for those individuals to then go on to have an investigative LDCT scan. And that's the human element, where even when we introduce a patient navigator, even when we made the scans free, people were reluctant to come forward for the next step. Could be a fear of a cancer diagnosis. So that is the challenge there, in raising the awareness. But the idea would be you do an AI-enabled chest X-ray, and the anomaly that is flagged up, the next step would be, along with clinical risk profiling, you would then be invited to have an LDCT scan, and based on that, you may need a follow-up scan, you may need a biopsy, and so forth. So, with regards to diagnosis, what are the challenges? Well, we know cancer care, lung cancer, any cancer, I think Dr. Nina will attest to this, cancer care is very complex, right? It's increasingly complex, very costly. Most cases need a multidisciplinary, multimodal approach. I think it's important that we it's an opportunity to end this silo mentality where surgeons work in isolation with the oncologists or the physicians. We've got to work together. We need to have more of these MDTs, collaborative discussions to improve patient outcomes. Even some of these can be done virtually. And with lung cancer, we've seen tremendous advances in the diagnostic and treatment landscape in the last 5 years. So the entire treatment paradigm has evolved. And this again reflects the value and importance of research. And I think it's so important that clinicians collaborate with industry and with also academia. We need to marry all three because it just all works well together. Now, I think in Malaysia, maybe 40-50% of the non-small cell lung cancer that we see is oncogene driven. There's a driver mutation, the most common being EGFR. And certainly for early stage disease, stage 1 to selected cases of stage 3, which is what I would operate on, we need to establish early on in the patient journey the tumor biology, not just whether it's a lung cancer, what type of cancer, but the molecular profile. Because it's very much personalized these days, whether the patient will benefit from some form of pre-surgery neoadjuvant treatment, some form of immunotherapy, or if they have certain actionable mutations, it may be they go for upfront surgery and then get adjuvant treatment. Now the challenge there, of course, in terms of the diagnosis is some of these tests are quite costly. There's also a turnaround time. And I think it's very important to highlight that when we're talking particularly about early stage disease, well and good to diagnose early, but the end game is intervention. And the outcomes, the prognosis will be determined by how quickly we can commence the definitive treatment. So the term we use is TTI. The time to treatment initiation is very important, okay, especially with early stage where we hope to cure. The objective of treatment is curative. So in this setting, there's an element of cost. There are laboratory turnaround times. It's very important. This is the challenge. Whilst we need to be precise, we also need to keep moving on that patient journey, okay? Because we don't want to miss the window where early stage potentially curative or curable resectable disease then progresses. And I think this also offers an opportunity where we have greater collaboration. I mentioned about research between clinicians, academicians, and industry, but also in clinical practice. You know, our Ministry of Health hospitals are fabulous. They are overburdened with volume and cases, and we need to have, you know, it has to be more than a soundbite, better collaboration, public-private collaboration. We can easily identify centers of excellence, high volume centers, whether they are in a private hospital, university hospital, government is irrelevant. So if you were diagnosed with lung cancer or breast cancer, you could then be referred on to these centers of excellence, integrated healthcare, where we can move the patient along that journey so that we can start the appropriate stage-dependent treatment, that time to treatment initiation. So that is very important. I want to finish with just this last slide, which is just for, I suppose, the non-clinicians here to have an idea that what is the complexity in terms of lung cancer management. So, you know, you get referred, obviously we need to establish the diagnosis, stage the disease, and then plan the treatment. And as I said, on top of histological diagnosis, the biomarker testing, the molecular profiling is very important. As a minimum, you need to test for these common genomic mutations. And debatable, but most would say we can test for the PD-L1 as well. With the exception of perhaps stage 1 or some very straightforward stage 2 where you know quite clearly surgery is the treatment of choice and you would operate first and then refer to the oncologist or pulmonologist who treats lung cancer. Otherwise, it's very good practice that these cases are discussed at a multidisciplinary forum, what we call as an MDT or a tumor board, to establish what is the best way forward. And it could be some patients proceed to upfront surgery, some patients need pre-surgery treatment, we call it neoadjuvant therapy, to downsize or downstage the disease or treat early on occult microscopic disease. And then following surgery, they may also need further treatment. And this is where, as Prof. Leong mentioned, the role of MRD, minimum residual disease. I'm very excited about that. We can look at the molecular basis of the disease, correlating with clinical and imaging as well, and maybe there's potential to escalate and de-escalate treatment down the line with serial measurements and very meticulous surveillance. The point being that the patient journey and NDT practices are changing because of the evolving landscape. So my final slide to conclude with regards to this topic of challenges and opportunities in screening and diagnosis for lung cancer in Malaysia is, I think we can conclude we unfortunately have a high disease burden, third most common cancer across the board and second most common in men. By the way, I didn't mention it's the second most common cause of cancer death in Malaysian men after colorectal cancer. And I apologize, it's the most common cause of cancer-related mortality in men, and it is the second most fatal cancer in Malaysian women. Only breast cancer is more deadly. And that is because the preponderance of late-stage diagnosis, late-stage presentation, poor outcomes, okay? So the way forward, I think, is targeted screening, screening-mediated stage shift, pick up the disease earlier when it's more amenable to curative. The gold standard remains a low-dose CT, but I think we need to embrace evolving, emerging, innovative technology, use it to perhaps identify and funnel patients who don't fit a normal profile. We then go on to have the definitive LDCT. In other words, address the high-risk non-smoker, majority of whom are women. And there are many theories about this. As I wanted to share the recent local advances, I think the Ministry of Health, our health minister is very visionary, and we have pushed forward this lung health initiative. It's something that requires a whole of society approach. Proud to say that we have also developed the first ever CPG for lung cancer. And what I would like to see and hope it's on the wish list is some kind of, I think the time is right for a discussion, or more than a discussion, for a national proper lung cancer screening program. What we're doing now is ad hoc screening, opportunistic screening, mostly in the private sector. But to make it meaningful, it has to be sustainable. To make it sustainable, we need funding. And perhaps they can ring fence the budget from tobacco taxation. If anyone knows the Prime Minister personally, send on the message. And finally, we talk about early diagnosis, screening, early diagnosis, but it can't stop there. Ultimately, the end game is to improve the outcomes, and that only comes from early initiation of treatment. So time to treatment initiation is very, very important. And here, I think it's important we leverage, we're one country, we're one society, it should be fairly seamless. Specialists, clinicians, researchers in the private sector, in universities, in Ministry of Health, we need to work in a way that we can identify centers of excellence, have a hub and spoke model, and be truly collaborative so that we can achieve better outcomes. I think I've overshot my time, so thank you.
May I invite Prof.